Hey guys, you are listening to the Dear Doc podcast. I am, of course, your host, Dr. Christopher Hoffpauir, coming to you from my studio here in Alvin, Texas. Today we have a guest that is more special to me than many, and that is because this guy used to teach me in dental school. I learned a lot from him, not just about dentistry, but about life and business ownership. I'm going to let him go through his past real quick as to why you as a GP should listen to him. But without further ado, Dr. Sergio Ortegon. Hey folks, welcome to the Dear Doc podcast, where we discuss the practical aspects of running your dental practice, as well as the technology, softwares, and services that can help to empower you as a dentist. I'm your host, Doc Hoffpauir. Thanks for joining us for today's episode.
You love dentistry, not software headaches. Juggling multiple pricey software that don't work well together? That's expensive and inefficient. Switch to one that does it all and cuts costs. That's where Archie comes in, an all-in-one cloud-based software that lightens your workload and can save you up to $8,000 per year. No more pricey add-ons, just one modern software to power your whole practice. Archie has all the essential clinical tools you use in your day-to-day. From tooth charting to treatment planning, even imaging is directly built in. When it comes to the intricacies of explanations of benefits processing, Archie delivers a revenue cycle management experience that streamlines every step, and easy-to-use reporting that provides unmatched insights into your business. Integrated patient engagement empowers you to text patients directly. Automate recall and appointment reminders. Enable online self-scheduling. And online forms are even built in. Easily process in-person and online payments. Increase your collection rate by storing credit cards for future use and collecting prepayment through Archie's wallet feature. Within Archie, you can even manage payroll and pay your team. Don't let your software hold you back. Visit archie.com to learn more.
Sergio, how the hell are you, man?
And good, Chris. Thanks for having me. This is a good, relaxed environment to chat again. I know we're talking through Facebook. You're an excellent group page. I've learned from it quite a bit, and I'm glad to talk about you guys about our symposium taking place in Houston, Texas, and April 12th and 13th. I'm going to talk a little bit about me, right? Guys don't know me. I taught at UT for many years, as full-time as part-time. Now I'm like a volunteer basis. But my story is like, I'm a prosthodontist that practice in Bel Air, Texas. And I did my fellowship at MD Anderson. And MD Anderson was the one who brought me in from Connecticut, where I did my pros training in AGD. Before becoming a prosthodontist, I did general dentistry for a couple of years out of my mom's office, who was an endodontist, right? And then my process to become a specialist, I realized I needed a little more skills, a better way of doing my plans. And I did an AGD, and then I did pros. But once upon a time, I was a general dentist, and I really wanted to do more advanced things, and I decided to become a specialist, right? But so I'm Colombian. I was born and raised in Colombia, did high school in the British school back there. And then I just moved to the U.S. to seek a better life. And my passion was pros. So I just got into the pros residency in Connecticut, and I established a home here in Houston, Texas. And I have my private practice, and I collaborate with a lot of former students, with a lot of faculty at UT from also different hospitals, MD Anderson Methodist. I provide services for them as well. And we have a little group that are putting together this fantastic meeting for you guys to learn and touch base about digital dentistry. We're going to talk about different topics, not only the implantology, but also we're going to talk about orthodontics, the movements, some restorative, and the highlight of the meeting really is the two guys we're bringing on the first day, which is Palomalo and Wildcat. That's unprecedented here in Houston, Texas, and you're gonna have a ball with those guys and learn from their digital process and how they evolve from the analog process to a hybrid process to a digital process, and how digital is coming here to stay, and how this might work towards enhancing your skills and technology set in your practice, and how you can incorporate this in your daily basis and make dentistry more predictable and actually help the bottom line.
That's fantastic. So guys, we are going to cover all of those topics and more. We're even going to talk about some more personal stuff in this interview. But without further ado, let's get into it. Can you talk to me a little bit about the location that this lecture is being held in and the dates? And then we'll go over a little bit more in the specifics of each date. And I'll just ask you a few questions and get you to do some short answers to each one.
Got it. So the symposium is going to take place at the Hyatt Regency Hotel in the Galleria area on April 12th and 13th. 12th is Friday, 13th is Saturday, and it's going to be whole day sessions, right? It's going to include lunch, coffee, and some beverages throughout the day. So that's basically the logistics of it, right? Main core lectures.
Fantastic.
On Friday, breakout sessions, workshops, at least 12 of them on Saturday, in which when you're registered to those workout, so when you register to the symposium, you'll have a chance to pick up your breakout session, right? You cannot pick up all 12 of them, just 3 of them. And then some of them are starting to fill in, or some of them are already sold out, right? So I guess I encourage everyone to sign up as soon as they can.
Well, if you had Hermione's time twister thing from Harry Potter, you might be able to get all 12 at the same time, but person can only be in one place at one time.
Yeah.
So, talk to me a little bit about the number of continuing education units that this is providing, and what section of communication of continuing education it is under the ADA rules, as well as what the cost of the course is.
General admission, I'll start with the registration fees. General admission, the regular is $950, right? Faculty member is $450, right? Students and residents is $150. Hygienists and staff is $150. So now I'm gonna give you it gives us a bunch of C credits. Let me just 1 second. I go back to that. I guess you can edit that until I find the number of credits. How many credits? Hold on a second. Yeah, you got me off guard there. Let's see here. Yeah, 1 second here. Trying to see. Okay, so you can get up to 14 hours of the credits, right? So that means that if you attend the 3 workshops of on solvable and the 2 main lectures on Friday, you'll get up to 14 hours of C credits. And the organization is actually it's a approved provider, right?
Which means that they can actually provide your PACE and cert credits over to ADA AGD rather.
Yeah, it's approved. It's approved provider. That's for sure. So I asked about it. I don't know under what institution they're doing it, but they filed paperwork to be able to provide the credits that you can use towards your license renewal.
Excellent. So guys, I mean, that is a pretty darn good value. That's under $70 per credit hour that they're providing, which is, me, I'm the business guy. That's a really great cost per hour of CE. And the other thing is, single crown is not the same as FPD whenever it comes to implants. And FPD is not the same as a roundhouse. It's not the same as a full hybrid. And all on four, or as someone I know used to call it, all on the floor.
Yeah, good. Remember
it's just not the same. Learning the workflows that are specific to each method and how to create a hybridized system between traditional verification jigs and a full digital workup, or doing it fully digitally and doing it right, is so important, not just to the outcomes and to the patient well-being, but it's also important for the bottom line. There's an old saying, there's always time to do it twice, but never time to do it right.
Yep.
This is the kind of course that's going to teach you how to do it right so that you don't have to pay twice for your materials. You don't have to pay twice for your time, and you don't have to pay twice in annoyance of the patient because it's taking longer than it should. All these things, they hit the bottom line. They make your practice more profitable, and they make you a better dentist. I can't see why anyone wouldn't want to go to the CE.
Yeah. It's amazing how things have changed in digital dentistry and implant dentistry in the last, I would say, 12 years. I used to, everything was physical, right? Tries, surgical guides. And it was predictable, to be honest with you, but there was a lot of steps involved. And I remember talking to a lab technician.
It was predictable if you followed the right workflow, and it was predictable if you had a lab that knew you and you communicated well with that lab.
Exactly. So I was going to say 12 years ago, it was just everything was analog work, right? Coming from the appreciation for aesthetics, occlusion, visual abilities, and hand skills to, say, set up teeth, right? To in the ideal position for a full arch reconstruction. But it became streamlined at different levels of accuracy, right? And ability of the practitioners and of the lab technicians. One time talking to a lab technician, he said that he was really happy with the all-in-4s because he realized that a lot of practitioners were having a lot of trouble with them. But the only way they could fix those issues with the prosthesis was through him. So he was making tons of money with this redos, try-ins, multiple repairs to the acrylic that was breaking off the prosthesis or breaking off during the conversion phase, right? And it was a learning curve, right? Some people got better, some people got burned after 3 or 4 failures. Look, I'm losing too much money. I already collect from the patient, but all these redos and extra try-ins to get to the end is costing me money. Every appointment that takes me to get from the immediate conversion prosthesis to the end, that it takes time from chairside time from my staff, starting from the front desk assistant. Your time, right, takes time. So if you start and finish in 10 appointments, right, it will be just not practical nowadays. Now we shorten that time, which makes everything more profitable as long as you're working the right way. And that way will be nowadays with the digital workflow. Working with the right people. And you can do a hybrid of analog versus digital and still be pretty good. It's just that because you guys have to partner with the right lab, right? Better if you have an in-house lab. I have an in-house lab because I realized I needed that support. But then I also worked some outside labs here in Houston who are really skilled, which actually some of them will be present at the meeting because they're interested in different data acquisition systems that they're in the market, but they might be too pricey for a private practitioner to acquire themselves. So they are a source of, say, just to give you an example.
And I'm guessing you're talking mostly about the extraoral scanners that actually use fiduciary analogs that screw into the implant so that you can plan the prosthesis based upon extraoral and intraoral scans.
Yeah, exactly. That's a step that stereophotogrammetry, right, which is it's an
Right.
impression system, right, that is of the implants in multi-unit implant cases. That is the landmark is stereophotogrammetry, right, where that comes with some flags, some dies, and your camera, right, and that data could be saved in a jump drive and could be married to another set of data in through exocad or other systems. That's the landmark. But then below that, there's those other systems called photogrammetry, which is
Right.
you don't have to acquire the whole system. It's just you have to have an intraoral scanner, right, and the flags, right, or anything that you can bond in the mouth and glue in the mouth or glue out of the mouth, just using your intraoral scanner. And there's difference between both of them, right? Some people swear by them, but some people don't like them too much. And then there's some literature behind the stereophotogrammetry and the photogrammetry, right? And there's different levels of skill set required to do the stereophotogrammetry and also the other one. So there's just pros and cons of both, right? I'm lecturing about stereophotogrammetry in the second day, but I know there's some colleagues of mine, prosthodontists, who actually have used the other photogrammetry systems like Nexus and other brands, and they run into some issues. For example, the system, one of the systems of the flags using just the intraoral scanner, they have if you buy into that, you have to buy into their ecosystem, which
right.
It's a topic of discussion that we'll talk about this on the workshops, and I bet you Dr. Palomalo and White Adam talked about it, how dependent you become to a company that drags you into an internal ecosystem, doesn't let you out, right? So to me, I'd rather be open, right? Honestly, so it's just let me scan it, let me take it anywhere I want. That file has to be, accessible anytime to anyone, so I can ship it out if I want to for someone else, third party, to design. If I'm too busy, comes back to me, I'm nil, right? So that's a business aspect of it, right? So how much time is my lab spending designing that you can design in Hong Kong, right? But as long as you have control over the fine tuning of the final design and you're processing right nearby to keep the warranty, right, of the prosthesis, that's important, because the outcome, not short term but long term, counts for the bottom line and for your practice and your how do you call it, your goodwill, right? So goodwill is what brings you more patients. Your referrals are happy with you because things would not only work in the short term, mid term, but also long term. And it's
let's face it. Let's face it, the high tech aspect of a practice, and so guys, full disclosure, Sergio and I used to talk. 2011, before I graduated, I actually remember a specific conversation. You kind of rolled your eyes at me. I said, one day we're going to be able to take a CBCT and we're going to be able to print the joints, and we're not going to need this stupid articulator. We're almost there.
Yeah.
So I know we're there.
We're there. We're there.
Right. Well, it's just not in common usage.
Yeah.
It's just not in common usage.
But
guys,
we're there. Actually, we're there. So now there's a company who actually is going to the lecture and is actually presenting something about extraoral face scanning, right? And then when you scan your face, right, and you use like an open software, right, you can import not only the face but also the STL of the teeth and the CBCT where your joints are, and you can capture some movements, right, within that file, and then there you go. You have your articulator right there.
I'm gonna make another prediction. We'll see if I'm right here. To me, the ideal thing that needs to be added next, because it is something that is entirely missing right now, is the ability to calculate the vestibular free space during movement. I think that we're going to have a wireless camera that you can just put a TAD into the palatal suture. It's going to click into place. You're going to have your patient go through opening and closing, jaw movements, protrusion, retrusion, and tongue movements. And it's going to be able to scan that and then recreate it. I'm going to say 5 years from now is whenever it's going to hit the market.
Uh-huh. So that not only
and it's going to change a lot.
So you're talking not only mandibular movement, but also like the dynamics of soft tissues, right? How
Absolutely,
that interacts
because
with
the
soft
problem
tissues.
right now is soft tissues are so hard to capture with an STL scanner, and extraoral scanners don't really capture it well. So the one component to me that's still missing in a really, really well done workflow for a fully digital workflow is vestibular space capture. Because if you can't capture free space, you're going to have issues with buccal cusps that are a little bit too far out during closing, and people are going to bite. Now, these are problems I had in my own practice that because I had a hybrid workflow, and I think everyone kind of has a hybrid workflow rather than fully digital right now because of that. I was able to correct those issues because I could look in the mouth and see what was happening, at least until the point at which everything closed. I think that would just really change the field.
Definitely that dynamics of soft tissues and mandibular movements that we don't have yet, right? We just see the static extraoral, some intraoral retracted views when pairing the STL of the teeth to the CT, right? But we don't have the dynamics per se, how things will look like. But that's where maybe and we've had this conversation with residents as well, where we fall into this trap where we have a lot of digital offering, recording devices and analyzing data, but if we don't have a basic knowledge of the analog world, why are we doing this? Then we can fall into this trap of like we have all this technology, but we don't know how to apply it and work with it. Then it's going to be really hard to make it work. Right. So just going back to your comment about mandibular movements, we have something similar that does not have soft tissues, what is called the mod jaw, right? So tracking device.
Right.
But so right now, for example, I don't use it right now, but I know of a lab that actually provides a service, right? So it is an extra layer, right, of say the patient's a Bruxer, or you worry about your full mouth rehab falling apart, right? Then maybe going that route might be worthwhile, right? Just to minimize the adjustments in the mouth or prolong the life of the restorations or off implants. And I think we have to pick and choose case by case which route we're going to get with specific patient depending on risk factors and establish prognosis of the prosthesis, right? So it's not for every single patient that we can do the same workflow. Some of them will be shorter. Some of them will be slightly longer. Some of them we have to add the mandibular movement feature, right? Some of them we can get away, which is not extraoral 3D face pictures. We just do regular pictures, different angles. Maybe we have pre-extraction records that are useful, so we don't need too much, right? So we just got to be smart about it and see how we're going to go all out in digital dentistry for every single case, which I don't think is the case, right? But you can choose which one works for you, right?
Absolutely. And that's the beauty of a course like this, is because you're exploring all these different technologies and how they intermesh. People can see the pain points and they can say, okay, that's something I can deal with, or no, I still want to use a verification jig before I go to final process. And the thing is, it gives you choices. The best dentist in the world is only as good as the number of choices he has whenever it comes to fixing a complex problem. And every one of these cases is a complex problem. It takes some true understanding of the functioning of the orognathic system in its entirety to do one of these cases well. You have to decide, am I going to put my patient in group function? Am I going to ensure anterior or posterior disclosure? And that comes down to that patient. It's not an all or nothing, one size fits all type of a situation. And that is where people get into trouble, is they're taught to do something a certain way, and that's the only way they know to do it. And so whenever a problem arises with that, a course like this, guys, can really save your ass, because you'll think, I always do this, but in this case, it's not working. What other choices do I have?
Yeah.
Choices are power.
Yeah. Yeah. You're right. So like, I think like when Paul Malo is gonna talk, and he's gonna probably show the evolution from where he started to where he's at now. He has to be doing something right. He has a huge building, huge clinic, a lot of general dentists, prosthodontists working for him, a big lab, and he has the workflow lined up. But within that workflow, I understand. For us, for example, to have a class 2 patient is different from a class 1 patient in a full mouth rehab reconstruction. When you have to increase vertical, right? When you have non-restorable teeth that are all over the place, type of roller coaster occlusion, you don't even know where to start, right? So those are the cases that take longer to plan. But once they're planned correctly, right? And these cases are, as long as you know where you're going to have teeth, the digital workflow works pretty good about it. And the closer you are to get to the ideal tooth position, the least amount of trouble you're going to have when doing the conversion prosthesis, which we're going to talk about it, sequence of doing that, and then pitfalls of that as well in these lectures.
Absolutely.
So by we get closer to where we want, we spend less time doing the final prosthesis, all right? And there's some discussions as well about between the conversion prosthesis and the final, should we do a functional prototype, which in my hands, I always do for 90% of the cases.
I do too. I wonder where I learned that.
Yeah, exactly. So just to be safe, right? And then it's easier to adjust or change things in 3D printed resin or acrylic than just having to do it in the final ceramic zirconia prosthesis, right? So, and there's some cases where we just go off like path, right? Because maybe against a denture, or we have the vertical already set up for us, and it's just different workflows. But I know that things will never be the same, right? After this symposium, you'll see what we're doing. And say, for example, in my case, I was a non-believer on stereophotogrammetry, right? Like, well, how much time does it save, really? So I had my workflow already, the analog part with some digital, but I never thought about stereophotogrammetry until I attended one of these lectures, right? And after talking to some of the practitioners that had the systems in their practice, and I really convinced me, okay, so this in my hands is the way to go, because I do enough where it represents not an expense, but a tool that I can make it work with patients and make it run some efficiencies for me, which at the end will be better for the bottom line, more predictable. And so I convinced myself that I really need it because I saw the need. But I did a financial study and study my workflows and see where it's fitted in my workflows. Right.
Hey, folks, before we get into today's program, I'd like to talk to you a little bit about one of our sponsors, DocSites. DocSites provides affordable and effective websites for dentists with no long-term contracts, transparent pricing, and great customer service, starting at only $59 per month. They also provide optional online marketing packages to help you increase your online visibility. For special offers, including up to 25% off of your website setup, text podcast to 818-489-9823. Again, that's 818-489-9823. Now, this is a limited time offer, so text now and lock in your savings. Or you can visit docsites.com/TBOD for more information. See, that's why I love you. You actually think about the money and say, am I going to make my money back on this? Does it make sense?
Yeah.
You know, one thing to throw in here is there is a difference, guys, between a skeletal class 3 or class 2 and a dental class 3 or class 2. And that is definitely something that you should be aware of when you're planning these cases. You really can't make a skeletal class 3 into a class 1 occlusion. However, you can kind of fake it, but that's a little bit more of an advanced technique.
Yeah.
And you better know what the hell you're doing.
Yeah. And like, just to go back to your point, to this point, so I have a implant center that is spread throughout the U.S. had this prosthodontist actually moving from practice to practice every 5 years, right? He would just do as much money as he could, like did a lot of all these large cases, but he knew it was just like operating on the base of like just the financial aspect, that they're really paying attention on these issues where maybe he was making all these patients that were different class 2 or 3 into class 1, but not every single patient will work well in there. So at the end of 5 years, he knew things were falling apart, right? And he would just like jump to other practice, right? So you gotta be careful, because if you establish practice and start operating like maybe too fast without acknowledging some issues that might happen down the road, you might shoot yourself in the foot, because it just takes 1 or 2 cases that go wrong to like maybe create a precedent around your colleagues, right? And around your patients, where it might make you stop doing those cases because you got burned, like lost money, lost referrals. So the finding is really important, right? And you don't want to be moving practices every 5 years.
What more concerning to me is that as a GP, our standard of care is to do what the reasonable dentist would do, right? And that generally is set to, if you're going to do something that's a specialty function, you must function at the level of the least trained specialist, is really kind of what it is. Not necessarily the best specialist in the field. And so whenever you have someone who's doing this, who is a specialist, it actually lowers the standard of care and the expectation unilaterally. And that's alarming. So guys, if you're a boss out there, this is a class for you too. This isn't just for GPs. You know, figure out what the highest trained specialist in the land is doing. You know? And in just going back to there's digital ecosystems. You know, I don't even do ortho, like Invisalign cases, right? Like it has recently changed quite a bit, not only with the brand Invisalign, but other softwares and companies who are doing almost the same thing at different levels, right? With different, I would say, tools of artificial intelligence, right? And obviously has come to where the outcomes have improved in all the systems significantly, right? And in some cases might be just better treated with some other well-established companies, but other cases might just don't need that level of accuracy, right? So I know you're part of one of those companies, right? So I know that artificial intelligence also is making a difference, right? With the human touch, obviously, right? And then the knowledge about like biology of tooth movements and so forth. But I know that it's maybe nowadays an open game, right? In terms of being able to move teeth with the use of artificial intelligence, and how predictable it is, and probably orthodontists will touch base around this topic, right? But also in the breakout conversation, if you say you're present there, someone has experience with different systems, I would say we'll have some interesting conversations, right? Between like people that have only experience with that one company, other that have experience with different companies, and see how different it is, right? And how predictable they are, right? So you probably know more than this than I do, but well, one of the points I was going to make there in response to what you're saying is that a rising tide raises all ships. Unless a company, Align, for instance, has the money to develop their own unified AI system. Well, most other aligner companies, including ClearCorrect and some others that I could name off the top of my head, they don't have the money to train their own systems, which means a lot of these people are renting usage of a just different types. I don't want to get into different types of AI, but they're trained by all of these different companies, and the results of all of the different companies are unified because they're using the same model. And so, since it's not a proprietary AI, now Invisalign may have one. I haven't actually looked into that to see if theirs is proprietary or not. But as an industry, the data that's used to train these will be the same data, and everyone who uses it, every bit of data that we have that makes the model better makes it better for everyone. It's really an exciting time, and in a best case use, I think, whenever it comes to dentistry, is using these unified models that are being trained over several hundred different sources. I mean, EBD, right? Evidence-based dentistry. the evidence is there. The thing that AI does for us is parsing that data in a meaningful way. So it's exciting you guys are teaching about that.
Yeah. So we'll chat about it, and then how the patients behave or react different to different biomechanics, right? There's still a place for braces, and then I know there's a system that's going to be spoken by a practitioner that does special things with special systems with a wire that goes in the lingual surface, and expedites the teeth movement. And some of my best referring orthodontists, they also believe that brackets are here to stay for some of the patients, right? Because their movements seem to be a little more predictable, right? Now, in terms of that, kind of like comes to play as well in cases that are larger, like cases that will need orthodontic surgery, right? How much of this teeth movement preparation is being done with artificial intelligence and then clear aligners versus conventional braces, right? And how predictable that is. So we're going to have a conversation about it as well. So see it in the hands of the orthodontists that are going to run the workshop and the surgeons who are going to be there present as well, how they are managing those cases, because it's interesting to see how things are changing with the use of digital dentistry. Also, right, I was going to make emphasis on some of the softwares that are out there, right? For say implant placement, there's some softwares that they marry the SDL, right? They marry the CVCT, and then allow you to come up with a surgical guide, right? But there's some softwares. I've had this conversation with some of my referring periodontist periodontist oral surgeons and general dentists who have this software. They're doing their own implants, but the softwares typically they don't have the ability to create a prototype of where the teeth are going to be, right? So if they have it, it's just like a mock-up tooth, but it's not really the truly software that creates what you mentioned, the ideal overlap, right? Overbite height, right? Versus profile. So I've had some issues restoring those cases that come from them because they didn't use the real tooth software to do the architectural shape of the teeth, and it comes to me and then I just have a hard time. So I would say we'll touch base about this topic in our lectures about how types of software influences tooth anatomy and actually the surgical outcome, right? So there's closed softwares, there's open softwares.
The library that you use.
Yes,
the library that you use not only affects the occlusion, but also affects the aesthetics. You've got to know enough, or at least your lab technician has to know enough to pick the appropriate model to accomplish what it is that you're trying to accomplish.
Yeah.
You know, it's there's a lot out there, guys, but this technology really, really makes it a lot simpler. And I know there's a lot of terms that surround this type of technology that really kind of cause some confusion or create obfuscation. And that honestly, to me, is the best thing about digital dentistry, is that they're trying to get rid of that obfuscation. They're trying to make sure that these processes are as easy to understand as possible, because then they're easier to do. Yep. So I want to define a couple of things here.
Sure.
If you heard us throwing around the term STL, that means stereolithograph, guys. All it is, imagine a JPEG or a picture, right? So all it is a picture composed of thousands and thousands of tiny triangles instead of single points. Now, the triangles lend themselves to creating a three-dimensional volume or a voxel. So these voxels are overlaid with the voxels created in a diacom. Now, the difference is the volumetric anatomy, or the volumetric space, or the 3D space, is calculated by the computer whenever you're using an STL, as opposed to actually existing in a diacom file. So what they do is they just look at the outside of that diacom file, they overlay that with the intraoral scans, and they make sure that those two pictures agree with each other. And that's what's called a fiduciary marker. Basically, fiduciary marker is just a way of saying there are little points on each picture that come together perfectly, and the more number of points that come together, the more accurate the model is going to be considered. So That's the first step that you need to know whenever you're looking at digital dentistry. Once you get all that in your head, you can begin to see that basically it's the same thing as kind of like an Invisalign suck down or an aligner suck down, where the aligner suck down itself is the model that's created by the intraoral scanner. And the model of the jaw would be your impression. And whenever they marry each other well and you don't have a bunch of warping in your aligner, we all know we've gotten that, right? That means that your model is highly accurate and can be used to do some really, really accurate high-end work that you can depend on.
Yeah.
So that I think that's some basics that everyone needs to know when they're starting to look at this. The rest of the stuff that we're talking about is ancillary to that and just makes the thing work. Good. But if you have that root kernel of knowledge in your head, it's going to be a lot easier to understand these more advanced concepts. Is that fair? And did I miss something that you think that the beginners out there need to know?
Yeah, I would say you describe it technically really accurately better than I would be able to describe it. But yeah, there's a lot of now softwares have the ability to look at 3 different points. Say you have an impression done with alginate, right? And you have an STL image, right? And you have an extraoral 3D image. The softwares should be able to, as long as you, right? They're doing this automatically nowadays, right? Where you just input the different layers, and then the software, if you can identify like 3 different spots, it automatically will marry them, will make one mesh, right? But there's some other software that you have to tell them, say, let's look at like the extraoral picture with the cusps. We have incisal edges, cusps, and then tips of the premolars, and then you kind of highlight those, and we have the STL right in that same ecosystem, and then you highlight the others on the STL. So the system will just marry them together. Right. Same happens with if you're working off, say, a Straumann software, say, for example, there's visual or co-diagnostics. You have the CT added to that. So like you have the CT, and then you just basically add those layers to the CT, and then you can actually, what I mentioned, in the same ecosystem, create an STL file, like a mock-up where the teeth need to be, and marry that as an extra 4th line of mesh into that main area. And you can create a predictable cervical guide then. Or it goes to orthodontics, probably just create like how like a progression looks like in, say, Invisalign, where it shows things, how they move, and then you can visualize that, and then the patient can visualize that. So it could be a tool for education, right? For maybe just a sales like tool as well. But also in our field, say, where teeth are replaced with implants, then also gives us an idea how things are going to be, and we can pair that into a image that the patient should be able to see the before and after type of feel. Right, which should be a lot more accurate than there's less powerful softwares nowadays that where you can crop out the teeth, put out a set of teeth, and then show to the patient. This is going to look like, but it's more like a
don't ever set an expectation like that.
Yeah, exactly. Because then I remember Dr. Beecher used to, I guess he has some he used to said something about it. He was part of a peer review committee. He got called once about a patient that was complaining about the aesthetics of their final veneers, and then the doctor had, done this mock-up, where it's like, this is the picture of the final, and this is how you're gonna look like. And then the picture was totally different from what he was able to come out. So the patient and the dentist and settling for something where the patient was right and the dentist was wrong, because the difference was way far off. And so I would say the closer you are in predicting the outcome and closer to reality, right, the better it's going to be. Because yes, nowadays patients can use that as a tool against you, right? Not everyone can have.
So guys, read my lips. Aesthetics follows function.
Yeah. Yep.
Say that to yourself in your head. Aesthetics follows function. If you have the function nailed, You can design the aesthetics around it, but you can't design function around aesthetics.
You're right. You're right. Not everyone can have Julia Roberts' teeth and smile, right, and upper lip function, right? So, but if you promise something like
She's
that,
got a lot of gum in that
yeah,
smile. I'm not sure I like that one.
I know. Like, imagine that in a hybrid case, how much bone you have to take out, right, to be able to.
Absolutely.
Like, it's or maybe, it's just that she will show that junction, right? That it's different layers of knowledge that have to be applied to the ecosystems nowadays, and working with the right team that will help you accomplish a final goal, which is what you need, right? So this symposium will show some aspects about how we can use this digital tools nowadays to come up with a final outcome, whether you're doing full arch implant reconstructions or orthodontic movements, or even there's a workshop, really nice workshop about designing resins with digital intelligence, digital workflow, and transferring that into the patient, which is kind of bread and butter for some. But then this technique seems to be more predictable, a little more less time consuming, and at the end more profitable, right? So maybe do like a full arch of like resin veneers, direct resin veneers might be created by hand, doesn't make sense. But if you have a pre-op and you have everything done before you start, and you can transfer that into the patient's mouth with different, more, predictable technique, it cuts your chair time like significantly. All the work has been done out of the mouth. All you have to do is inject, for instance, in the mouth.
I'll tell you, man. So I did, as you know, I've always been a huge technophile, and I was really on the cutting edge of a lot of these whenever I was practicing. And I remember having to use Mesh Mixer to marry two STLs, overlay an STL of the ideal wax up, because we'd actually get it waxed up and we'd scan the wax up, mounted and everything, and then scan it. And then we would do injection molding. But the trick was always making sure your separations were perfect enough that you could slide little pieces of plastic in between each teeth, and you had to separate the teeth enough in the mouth, cause just enough space so that it was going to be easier to individually section these things. Yeah. Then you had to do injection molding on top of that. It's a lot of different things that goes into it, and a lot of levels where you can fail. The more individual steps, the more failure, people. So one of the points he's making here is that these models and the software has really come a long way. If you're the kind of guy who was like me and you got in earlier and you're like, hey, I'm going to use Blue Sky Bio, and I'm going to print my models, and I'm going to plan my implants. I'm going to create my surgical guides. I'm going to create my reduction guides. I'm going to create my PMMA temporary so that you can go to your final later. There's a lot less steps now. If you got overwhelmed in the beginning, whenever you're trying to do this, guys, you need to go and take this course, because it's going to give you a breath of fresh air. If you're still doing it the old way, come and learn some new ways to do it. Learn some new options, get some new choices. One of the points I want you to speak about really quickly here is interdisciplinary work. One of the things that I noted whenever I was doing this kind of work is that most dentists didn't think holistically whenever it came to the way they were planning their cases. One of the things I would do, let's say I had a deficient area.
Wow.
I might keep a tooth that I know was coming out and orthodontically move it, because by extruding that, you cause movement of bone as well. It's one of the few ways that we can very, very exactly control where bone is going to go. There's so much that goes into these planning sessions, trying to figure out how to do it the optimal way. And again, one more time, there is no one set way to do this. You need options. That's why you need a course like this. I'm glad to see you guys have orthodontics being covered in the same course. Yeah. Are you guys planning on talking about any of the interdisciplinary treatment planning there, so far as moving bone through orthodontics for implant placement, or is that something for the next symposium?
So I think so. Dr. Zabuti is going to touch base on something. So we work within the orthodontist a lot, and we we, for instance, say doing one arch of implants on the upper for full arch fix, and then you have good sound lower teeth, but the teeth are aligned, maybe super up on the lower incisors. So I work with them where he intrudes the lower incisors, levels the occlusal plane. Meanwhile, everything's healing on the upper, right? And everything's in a conversion prosthesis. But we collaborate through a digital platform where he sees where the final occlusal plane should be from my end, and then he incorporates that into his teeth movements, right? And we get to keep the lower teeth, right? And we just get to do our second interim and final prosthesis following the outcome of the lower orthodontic treatment. So we do a lot of we tend to be not as aggressive as other people might be, and
Right.
we do a lot of orthodontic movements, even in patients that that we know that in the long run, say 10 years from now, they might not get to keep those teeth on the one arch, for instance, but at least we give them a chance to stay.
Right.
And we work also as well. We have cases where we have multidisciplinary treatment where one arch is being treated by a periodontist, right? Keeping the teeth healthy, right? Same teeth are being moved by the orthodontist, right? And then the opposing arch, an oral surgeon had to replace implants based on our planning. So like 4 people involved in that case, right? And then, for example, if the case belongs to a general dentist, right? I will, although I have a hygiene service in my practice, I don't like to keep those patients. I like to send them back to the general dentist so they can maintain their teeth, the remaining teeth, and then the prosthesis. And as long as I see them maybe at least once a year, just to make sure everything's fine, we're good with that. So we have different team members within our plans. And I know and then they brings up another topic, which is maybe a lot of dentists maybe just doing a lot of things at the same time and not doing all those things at the highest level, right? So in my case, in my ecosystem, I chose not to do any surgery, right? And why is that? Well, I was probably going against, like, when everyone's throwing themselves and diving into implant dentistry, I was just like basically backing up in surgery because I know some periodontists and some other oral surgeons who would just do oral surgery and periodontics and surgery really well, and they're not doing a lot of pros. They understand pros, right? But I'm not there to compete against them. Actually, I'm providing them the pros services of planning together and then executing the end result, but using both our minds and our network abilities, right, to be able to come up with a solution. So and in my business, I was in my ecosystem. I was like a medium fish, basically. I don't want to be like taking food from a bigger fish, right? Because we all feed each other, right, with patience and thoughts and process. So I chose not to do surgery because I was getting a lot of referrals from these surgical specialists, right? I didn't want to compete with them, right? Plus, if I take one surgical case, I wouldn't be seen by good eyes, right? And so that basically based on ecosystems, right? My practice, but same with digital dentistry, right? So how much of digital you want to do in your practice, or are you going to do an analog or just a hybrid process? In my case, I think if I was starting, I would get good with analog, right? And start like slowly incorporating digital dentistry into the workflows, right? So maybe using a lab, third party, to help you out acquiring some images, right? And then digitizing some images, and then you understanding their point of view and how they're doing it, to maybe later on you doing it yourself, right? Or having more say of where the teeth should go before they come up with a surgical guide or a conversion prosthesis. So there's a lot of the dynamics of dentistry, I think, have changed with digital dentistry and also with implantology, right? And some people are more prone to like jump in and then do everything, right? From the diagnosis, surgical, and prosthesis, and they do pretty well. And so some others, and they'll try to like kind of like collaborate with other specialists. And if the other specialist, it's actually a more, I guess, developed in their systems, you learn from that specialist, right? And you feed each other, and the outcomes might be even better if you do it all yourself. So, but it depends also on the ecosystem of each practice, right? So I'm surrounded by oral surgeons and periodontists, right? And
Right.
skilled dentists who maybe don't want to do it all, right?
This guy wasn't.
Yeah, exactly. So if I was like maybe away from a good oral surgeon or good periodist, I would probably doing it myself, most of it with support though of maybe a oral surgeon, a periodontist, surgical specialist, just so we can collaborate still. But it's just the need of the community, right? There's someone that can do it all. Why not, right? It's just that's the way I think it. And financially works well for the dentist, and then helps the community, right? No harm,
Absolutely.
right? Yeah. So that's my point in terms of collaboration, right? I have to collaborate because that's my ecosystem.
Fantastic. Well, Sergio, thank you so much for coming on and sharing this AADD 2024 symposium with us and a little bit about what you guys are going to cover. Folks, you really need to remember something. There's a lot of dentists out there who say, well, I practiced for 20 years. You have a choice to make in your career. You have a choice to make in your profession. You can practice 1 year 20 times, or you can learn every day. A prosthodontist who practices 1 year 20 times knows nothing more than they did when they got out of school. If you're a pros out there and you're not seeking to change your mind, you're not thinking like a scientist, because scientists think, how can I disprove what I know so I know more? If you're not out there trying to learn, even things that you've previously thought just were flash in the pan or something that you wouldn't want to incorporate in your practice, then you're guilty of practicing 1 year 20 times.
You're
What's
right.
your thoughts, Sergio?
Yeah, you're right. Like, so you have to be an eternal student, right? You gotta like try to be
and
the best you can.
Self-critical.
Yeah, yeah. So if you don't learn from others, right? There's always something that you can learn from others, right? Either from resident student,
even the dumbest guy in the room can teach you something, even if it's only how not to do it.
Yeah, exactly. So I like to discuss cases with older prosthetized, older dentists, right? Because they have tools and they have techniques that I'm maybe not using that I might be able to use in my practice, and I share with them all my ideas, and I don't hold anything really when talking to them, right? I help former students with their cases, like they text me, they email me, and then they'll bring the case over, and they decide they want to run with them, like on their own. They can do it. At least they have a structure, right? So I think that if you get outdated, right, in your techniques and philosophies, then things will go right past you, and then it's not exciting anymore. I think dentistry might become just stagnant, right, in a practice where you're not pushing yourself to like be better and learn more things and become like really top of the game, right? And your patients will notice that, right? So patients will say, oh, how come so and so, how are their molds made with a digital wand and they never had any stuff in their mouth? I hate that stuff in the mouth. How come you're not doing that? Or my son had the braces placed or Invisalign placed in this place, and they made an impression. They use a digital wand, and then here they go. They have the retainers. How come you don't have that, right? And then patients are not dumb. They're just comparing things, right? So if you have like intraoral scanner, for instance, nowadays, it's just, why not? Why, right? It's not that you're going to do like 90,
and the economics 100%, of it.
Yeah, and it's not that you're going to do 100%
the economics
of
outperform using PVS or Algin. Yeah.
Yeah. So you still have to be on the top of your game with digital advancements or technological advancements in your practice to provide the best service possible. If you fall behind, if you practice same way you practice when you graduate, then you're doing a disservice to your patients, honestly. And then you just like, everyone around you and even your patient will notice that you're basically not up to speed. They might just move on, right? And then, it's just, you have to like promote yourself somehow, right? One that somehow teaches how I'm able to incorporate new technologies, digital dentistry into our practice for the benefit of all, right? If you're not doing that, then it's not a good thing.
Fantastic.
Yeah.
So, Sergio, I'm going to give you the closing words here. What would you like to leave people with? If you had one piece of advice that you could give all of the dentists out there who are listening to this broadcast, what would that piece of advice be?
I would say be the best you can for your patients, the best you can be out there for your patients. Try to like provide them the best service and then treat them as family, right? Use all your knowledge or your tools and be a better dentist every day.
Fantastic. Well, Sergio, thank you for joining us and giving us an hour of your time to talk about this.
More than welcome.
Thank you for all that you're doing to help educate patients. Well, guys, this has been another episode of the Dear Doc Podcast. Thank you for listening to this podcast. As always, if you find value in what we are doing here, please like and subscribe. Less than 1% of you guys who watch my videos actually subscribe to the channel. And the way that we get these videos out to other dentists so that we can help them is through subscriptions, because YouTube targets channels with the most subscriptions. So please go ahead and do that right now. I'm begging you. Until the next time, this has been Dr. Christopher Hoffpauir. I'll see you in the next episode.